I borrowed this diagram from the internet so that it can give you a highlight of the things that I want us to look at. So since we have not done the respiratory system, I'll just give you an overview of the structures that we have. Starting from the nasal airways or the nasal cavity, then we have the mouth. These are the entry points for air. And they come together, of course, from the pharynx at the back of the mouth, then you go to the larynx. From there, it divides to the trachea, or rather not divide it, moves on to the trachea, and the trachea is the one which will divide into two large bronchi. If it is one, it's a bronchus. If there are two, they are bronchi. Yeah? Each of these continues to divide and to become smaller as it divides further and further into the lung. And the tiniest of the air passages or airways is the bronchiole. Now the bronchiole balloons into structures that we call the alveoli, which are the areas for gaseous exchange. Now all these other places from the bronchiole, the bronchi, the trachea, these are conduits. They are just allowing air to move in and air to move out. So now, when we start listening to the chest sounds, we will be looking at placing the stethoscope around the alveoli and listening to what is happening as the air moves. Now the alveoli are so tiny, and in fact they fill up the lung, which appears like a sponge-like tissue. So when air is moving along the lungs, because you can hardly hear the sound, it is very soft. So this kind of breathing, when you hear the air movement within the lung tissue, we call it the vascular breathing. And then if you place the stethoscope anywhere around the large airways, that's what we call the bronchial breathing. So now you can distinguish, because one of them, in fact, when you listen to the sound of air moving, it's like a whole, you can imagine like a whole amount of air or wind blowing through a very big tunnel. The kind of sound you are going to hear here is just a whooshing sound, which is very loud. But when it comes to the vesicular one, it is very soft and far, but you can feel the consistent moving in and out of the air. Just because of the structure, you can see here it is large airways, here they are smaller ones, they are ballooning structures. And from there, I'm going to talk to you about the stethoscope so that now you can have a relationship between what we are seeing here and the stethoscope. So the purpose of this diagram was just to give you an overview and to see the location of where the lungs are. You can see just where the rib cage are. You can actually feel where your rib cage is. That's where you have the diaphragm. Anything above that will be touching on the lungs. So I'll stop sharing this and share the document that I had before, which is slightly different from the one you'll be using. It has a lot of similarity, but I have some additional materials here. So before I go to the different examinations that we are going to carry out, so we'll have several of them, but before I go to those ones, I want you to look at the equipment that we are going to use. Now I have here what we call the pinhead horn. By the way, are you able to see? Maybe I'm sharing and you're not seeing anything.
No, we can't see.
Yes. I have so many windows open, I thought that I had shared. So are you able to see now?
Yes.
Thank you. So for this particular lab session, we'll be looking at chest examination and abdominal examination. And we are going to be relating the two because this course looks at both of them. So now, the first one, I'm focusing on the chest because you normally examine from head downwards unless you have a reason to first start with the abdomen. So I will skip the first part and go straight to the equipment that you're going to use or the apparatus. You have one, the stethoscope, And number 2, I have a peanut horn. Now we are not going to use this one, but I thought it is good for you to remember where we came from in order to build it up to a stethoscope. I'm sure that all of you have played a game whereby somebody is in one room, say in room A, and you are trying to listen to the sounds, and there is a wall between room A and B. And what you tell each other is that if you put a glass next to the wall, and then you put your ear here, you are going to be able to hear what the person is saying. So if you put your ear next to the glass, if this is a glass, make sure it is touching the wall, and you put your ear next to the glass or even touching the glass. You find that the sounds that are coming from here are really, really magnified, and you can even hear what the person in the next room is saying. But when you remove the glass, you find that the sound is diminished. So the question is, what is the glass doing that you are able to hear? Now you find that the sounds that are coming from this room, they are very large waves. And if you try to listen to these waves from this other side, you can hardly hear them. What the glass is trying to do is to capture these waves and concentrate them within a tiny, tiny area. So they become more concentrated, and when you put your ear, you can hear what is happening. So they used this same concept and came up with what we call now the pineal horn. And with the pineal horn, what you do is you can place it next to, and actually it is used by midwives even current days. You place it in a woman's belly, and you can actually hear sounds that are coming from outside, from inside. And in this case, this is a pregnant woman. So this peanut horn is used to listen to the fetal sounds. So the sounds is coming from right inside, and what is happening is that as it goes to the surface of the body, it is captured by this white region here, but the sounds are then concentrated to a very small area, and when you put your ear next to it, you can really feel or hear the magnified sounds. So using the same concept, they came up with the stethoscope, and you can see that with the stethoscope here, it has a part, in fact I can show, this is part of it here. It has a region that appears like a drum here, and it is doing the same thing. So what will happen is that sounds will be captured in this area, concentrated to this part, and once it is concentrated to this part, it is taken through the rubber tubing, and this is the rubber tubing that you are going to hear. So to see, but you find that the rubber tubing has nothing, it's just a hollow tube, but it is taking all these concentrated sound, and then when it reaches here, it splits and it goes to your ears. These are the ears where you're going to, and these ones, if you look at the stethoscope, is nothing but a metallic region which is hollow. And on those are the ones that you call the biennials. Now what you're going to do is the sound will come, and because it is highly concentrated, you can see the outlet here is very tiny as compared to what you had here. So you find the sounds are really, really highly magnified. Now this area is what we call the drum, and you can see that it appears very well like a drum. And on this side it has a very light tubing which we call the diaphragm, and it's the one that fluctuates according to the sounds that are hitting it. So if the sound waves are appearing or they are coming in this direction, they will hit against the diaphragm, and the diaphragm will keep fluttering, and as it flutters, it will push the sound waves into the tube. And you find that although here we had a wide area, when they reach here, because it is smaller, they become more and more concentrated, so that within a small area, those sounds are trying to occupy that region. And for that reason, by the time it reaches your eardrum, it is really, really magnified, and you can capture it. So, like I said, we have the wide part which we call the drum, and then we have the diaphragm on this side. Now, as you can see, in modern stethoscope, we have two regions. So we have one that has a wide drum, and then we have another one that is smaller. It has the same shape. It has the same shape, same everything, only that the smaller one does not have a diaphragm. Please make sure you are muted, even if you come in late. So as I was saying, the on one side we'll have the larger piece, and on the other side we have a smaller area, but the smaller one does not have a diaphragm. Sylvia, I have just muted you. If you unmute yourself, I'll remove you. So as I was saying, I hope that you won't be interrupted again. So you have that area that has the drum on one side and a bell on the other side. We call it a bell because if you look at it, it just appears like a bell. It has no diaphragm, and then it has the connecting piece here. Then on this side, it has more, it's wider, and therefore it appears like a drum. So on one side you have a drum, on the other side you have a bell, and that area is what we call the chest piece. So once you know the parts of the stethoscope, this is what you'll be putting in your ear, and you can use either of these sides. The only difference between using one side or the other is a lot of interruption. Samuel, you're saying you can't hear me, or was this a message that you had sent earlier?
Now we can hear you. I sent it earlier.
All right. There are people who are joining in now, and every time I have to admit them, it is stopping the class. That's why I always tell you to come in good time. Anyway, so now what we'll be doing is, if you want to use, you can use either of these side. The only difference is that one listens to high frequency sound and the other one listens to the low frequency sound. Yes, Nicholas, your hand is up.
Yeah, I wanted to know whether you can make me the co-host so that I allow them to enter the class.
Thank you. And I have given you those. I've given you that. Okay. So now I won't bother with anybody who is coming in. I've given you the right to admit them. And I hope you know your classmates so that you don't admit a hacker. Okay, so how do you choose whether you're going to listen to use the drum, diaphragm, or to use the bell? So when you place it, when you're listening to the high frequency sound, usually you want to listen to one side and the other one will capture the low frequency one. So what you have to do is just to twist 180. If you twist this chest piece 180 degrees, then you're able to listen to one sound and not the other, because what it does, it will lock out the sounds from one side and just allow the other one to pass. If you want to use the other one, then you twist again, and now it will lock out this other side and it will allow you to listen to that. So now that you know about the stethoscope, the next thing I wanted you to look at is, what are we going to do with the stethoscope? It will bring me to the 4 things that we normally do when we are doing an examination. So we normally go to the hospital, you go to see the doctor, and you find that once you're told to sit down, the first thing they want to take is your history. Why did you come there? And then from there, after taking a lot of your history, they tell you now it's time to examine you. and you may be told to lie down or sit down on a bench, and they are going to check on some things. Now, there are several ways of examining if it is you're looking at just the chest. There is what we call the inspection, and then there is the palpation, the percussion, and the auscultation. So now, when it talks of the inspection, the examiner is just simply supposed to look at the chest without touching. They just look at the chest. They can make you lie down so that they can observe your breathing. They can see the way the chest rises and goes down as you are inhaling or exhaling. And one of the things they are going to check is to check that the left and the right side, they're actually symmetrical, so that when you inhale, both sides are rising at the same pace, and when you exhale, both sides are going down at the same time. There's also something else that they can do during the inspection, and that is they can place their hands against your chest, and they ask you to inhale so that they can see the level of expansion. And again, compare. I think it would be easier if I could do this in the lab, but since you're not there, maybe I can show you a video that later that shows you how you can hold on to the chest and check the chest expansion, and check that both the left and the right are expanding at the same way. And when you exhale, the same thing happens. You exhale and the chest lowers or becomes smaller in a symmetrical manner. Now, that is the first level of examination, because before touching, the only thing you have is the history and then the examination to see. The other thing you also want to note is if there are any swellings, any lesions, any scars that are on the body, because all those may have a story to tell. If you have a lump, something that is protruding, it may affect the way you are feeling or the way you are breathing. If you have, say, some soreness, again, even that one may affect. So it is good to observe whether there are lesions, whether there are swellings, whether there are lumps, whether there are scars. Maybe somebody has had surgery before. So all those are taken care of during inspection. Now, from there is a second component, which is palpation. And palpation, it comes from the word palpate, where you feel with your hands. In that case, you can do what we call just the shallow palpation. You place your whole palm on the region that you want to palpate, and using all your fingers, you try to press down and to feel the surface. Now, you can keep moving along the body doing all this palpation and feeling if there is any change in the inside of that subject. Then there is what we call the deep palpation, where you really palpate and you press to feel the inside regions. Now, usually the shallow one is catering for anything that may be on the surface, feeling if there is any soreness, feeling if there is any, shall we say, edema, checking whether there is any abnormality from what you normally expect. Now, when you start doing the deep palpation, you are trying to feel the organs, where they are, or if there is any tenderness with the deep organs. Now, from there is also another component of examination, which we call percussion. Now, for those people who have done music, there is something related to music here. So when you think of percussion, think of the person who hits the drums, because they have a rhythm to hitting. So that is what they call percussion in music. But when it comes to chest examination, when you do the percussion, you are utilizing the same concept. You will be tapping and listening to sounds. So what you do is with your hand, with your dominant, the less dominant hand, you place it on the surface that you want to palpate. Then using your dominant hand, you use one finger and tap against one of the other fingers. listen to the sound that comes back. So you keep tapping and tapping on your finger, and you'll be listening to the sound that comes back to your ears. Now, if it is hollow, you find that the kind of sound that will resonate back to your ears it will be depicting something like an empty container. So it is very loud and dull. Now, if it is a solid part, say like your upper chest, you percuss on the chest and you feel like you are really tapping on a solid piece of, I would say, object, something like the sound you get when you hit against, say, a table. So the sound, it's not dull, but at the same time, it doesn't last long. So it is a short, sharp sound. So that way, you can actually tell if where you are percussing is hollow. Say, for instance, if you have edema and you have fluid accumulation and you percuss, you find that the kind of sound you're going to get is different from when you have a solid part within that, a solid region, I would say. Now, in all these cases, we are listening to things or we are observing things within the surface. Now, when you use the stethoscope, it will be catering for sounds that you can hardly hear with your ear without assistance. So you'll be listening to sounds coming from within the body, from deep inside the body, but then in this case you magnify using the stethoscope. That kind of examination is what we call auscultation. Now, if you're doing it in the chest region, there are several things that you could be looking at. You could be listening to the air as it moves down the airways. Like now, I have just explained to you how the air moves from the upper respiratory tract. It goes through the trachea and to the lungs. And then as the air moves out in the opposite direction. So you could be listening to those sounds. Number two, you could also be listening to the heart sounds, because within the chest region, we also have the heart. And the heart is actually louder than even the air as it moves. So it will sort of mask the sound of the air if you don't focus your ear on the air movement. So there is the normal heart sound that you are likely to listen to when you're doing the chest examination. Now, because I've been doing a lot of talking, anybody who can tell me how else you can use the stethoscope? I'm sure you've all gone to visit the doctor and they've used the stethoscope on you. So apart from listening to the chest, how else do they use the stethoscope? Yes, patients. Unmute yourself, please.
Yeah, it is used to measure the blood pressure using the sphygmomanometer and the oscilloscope.
Oh, great. So do you know what they are looking for when they are looking at the blood pressure? What do they listen? Why do they put the stethoscope there?
They listen to the two sounds of the heartbeat. To the two sounds of the heartbeat.
Okay. Who else can tell me something else? Thank you, patients. When you have gone to the hospital or to the doctors and they used a stethoscope, where else did they use the stethoscope on you? Okay, so like I said, when we have air moving through a hollow pipe, there is what we call like the turbulence, that forced air movement. Now, this turbulence, you don't only see it with air movement. So in your blood vessels, as the heart pumps, you find that the blood will be forced through the blood vessels at a very high pressure. And then as your heart relaxes, the pressure drops. And once it pumps again, the pressure rises. So now when you're using this manometer, as patients have said, normally what they are trying to listen to is that movement of blood as it goes through the blood vessels. So they're going to place the stethoscope where they are likely to hear any blood movement through the veins or through the arteries, and they usually put them on the inner side of your elbow. So that's where you'll put your diaphragm and listen. The other thing they do is they block your upper arm so that by filling in the air or pumping in the air, it will balloon up and it will occlude any blood movement. So you don't feel anything. The blood will be occluded. Then what they are going to do is slowly release the pressure. And when they release the pressure, you're going to hear the blood as it fills up the blood vessels. So once you start hearing that sound, then you can take note of the pressure at that point. Then you continue releasing so that you can hear another level of sound as it's passing through the diastolic. So what you're going to, but all this will be shown in the lab at the right time, not for this particular lab session, but I'm sure you're going to do it later. So what I was saying is that the stethoscope can be used to listen to so many things, including the blood flow. So that was one way that you can utilize it to look at, to measure the blood pressure. So now that you know the 4 methods of examinations, chest examination, Grace Tuku, can you tell me one of them? One of the methods that we talked about for chest examination. Grace Tuku, are you in class? Just give me one. Is Grace in class or I put her in the waiting room?
She's typed in the chat.
Okay, I didn't see that. Let me see what she has typed. Yes, you are in class. Okay, answer the question. One method of chest examination. Instead of writing yes, you are just type there. One method of examination. So that I don't put you in the waiting room. So when you are using a stethoscope, you are listening. Remember we said 4 different ways of examination. 4 ways of chest examination. One, okay, you are telling us you are listening using a stethoscope. Anastasia, what did we call that when you listen with a stethoscope? Or anybody in class who can remember?
Palpation?
Pardon?
I said palpation.
Palpation. Palpation is one of the methods, but it doesn't use the stethoscope. Mustafa Eden, tell us another method.
The method which uses the stethoscope is the auscultation.
Auscultation, thank you. And then there is, I can see Grace has also typed. She's giving us different answers and different explanations. So she has typed percussion. Who can tell us what percussion is? Percussion does not use the stethoscope, but it's another way of examining the chest or examining the inside of the body. Who can remember percussion? What can it relate to which has nothing to do with physiology? Remember when I said it's, yes, Ivy?
We can relate it to drums.
To drums, exactly. So you are tapping. So Joy Moshemi, how do you use percussion to test?
You tap on the chest of the patient.
Yeah, you'll be tapping and listening to the resonating sound. Anai, what did you want to say?
Just basically wanted to say that it's just therapy of the chest where you tap on it, right?
Yes.
Said it.
So you'll be shown. I believe Kwena is here. He's with us in class. So he'll be able to show you the different ways of chest examination, the auscultation, the percussion, the just the inspection, and finally the palpation. So we'll have the deep and the shallow palpation. So any question that you may have so far? So as you can see, this person was examining the belly, but when they were examining the belly, they were really listening to the sounds of the fetus. And usually this method is used to listen to the heartbeat of the fetus. I don't believe we have anybody who is expectant that we can listen to, but we can go to our subjects that we can utilize to do chest examination. Now, the body can be divided into several regions. You can listen to these chest sounds from the front or from the back. So we have the upper region, and then we have the lower region, and of course we have the middle. So you can see all these portions. Now, if you recall where your heart, or rather where your lungs are, so they'll have a base to the lower side and an apex to the top. Now, if you look at again, here we have the sternum and then we have the ribs on it. So because we have the ribs crisscrossing here, if we place our stethoscope anywhere here, we can be able to listen. Yeah, you should use a different color. If I place my stethoscope here, I can listen to the apex, or I can listen to the middle portion, or I can listen to the base. So normally, if you're looking at the front and you're using the stethoscope, you want to listen to around the lung area. So you want to listen to around where the bronchial are. You have the trachea coming in, and then it will divide into the bronchi. So you want to listen to the apex. You want to go down, continue going down, and at this point you are likely to listen to the bronchial sounds. And then by the time you go here, you are listening to the vesicular sounds because it is far into the lung region. And the kind of sound you'll expect here is different from the one that you'll expect in this middle region. Why? Because in the middle region is where we have the large airways. So the kind of sound you expect here will be very loud as compared to what you find at the base or at the sides of the lung. So the format you're going to use when you're listening is from the top at the apex, then you go to the bronchi region, and then you go to the base. That way, again, it will become more apparent when you're doing respiratory physiology, because what you find is that at the apex and the base, it will give very different sounds, because even the amount of blood supply that is going or the amount of air spaces that are there are different. So you can be able to compare the apex region and the base region. And when it comes to the middle portion, you are really listening to the large airways. So this is for the front. As you listen to the front, there are times when you've been told lift your arm, and they would listen, or they would put the stethoscope on the upper region or the lower region. But the main reason I told you is to look at the breathing sounds at the apex and comparing them to the base of the lung. Now, when it comes to the back is a bit more complex, because in addition to the lungs, we also have, in the back, we have the scapula. And if you place the stethoscope anywhere on the scapula, you find that you'll not be able to listen to the deep sounds, because they'll be obliterated by the bone. It is a flat bone, and it will be blocking the sound. For that reason, when you are using the stethoscope to the back, you follow around where the scapula is. So you start from the top and you go downwards up to the base of the scapula, and then you go all the way to the base of the ribs. Now, as you listen, it is also very important that you are not going to go and listen to one lung and then follow it to the other one. Because if there is any discrepancy between the left and the right side, you will not be able to tell the difference. So usually, as you listen, you go in a zigzag manner. Listen and go that way. And when you go that way, you are able to compare each side to the other. So you'll be going left to right, right to left, that way, so that you're able to compare the sound you hear in one to the one you hear on the other side. Ideally, they should be the same. So if there is a problem, if say there is a clear sound on this side, but then there is a blockage on this side, you find that even the sounds will be different. So I think this part I will leave you to do with when you'll do the technical part. And then what I will come to is now, what are the kind of sounds that you expect? So we say that if you listen to the breathing sound from the bronchi, we say that is the bronchial breathing. It is very loud as compared to the soft breathing of the vesicular of those lung regions. So I want, when you go to the lab, you're going to compare by placing the stethoscope in the large airways, just on the chest along the large airways, and compare them to when you listen to the base of the lungs or to the apex of the lung. Now, I expect all of you will be healthy, so we should not have a problem with the breathing. It should be largely the same from one individual to the other. There is also another component I wish to bring in here. You can see that this subject over here has no clothes. We are not going to subject you to remove your clothes, so we can place the stethoscope largely on a t-shirt or a shirt, or so that you can listen through that and you'll be able to hear the sounds. So you shouldn't be worried, or you shouldn't be hesitant to volunteer to be the subject. So now, what are the abnormal sounds that we expect? Now, there are several sounds that we normally, I'm sure you've all heard from somebody who is in your vicinity, maybe a child or maybe a roommate. When they sleep and you hear that breathing as they are coming in, they are pulling a lot of sound, and when it comes out, it's like a snore. And that is what we call the rhonchi sounds. So we say they are low pitched and they are snore-like. And the way to recall this, you just listen to a child who has an obstruction and they are sort of like snoring, and the kind of breathing you listen to, that is what we call the rhonchi. Now, there is another sound which is more like somebody blowing a whistle. As they breathe in, usually the air is clear, but as they try to breathe out, there is a whistling sound. Now that is what we call a wheeze. And this usually occurs. Oh, by the way, I didn't say that this one is usually caused by obstruction, especially the rhonchi is caused by obstruction, especially in the upper airways. Now, when it comes to the wheeze, on the other hand, it is obstruction which could be caused by maybe excess mucus or maybe constriction of the vessels. And you find that when they're breathing in, there is no problem with that. And the kind of sounds that you're going to get, or the kind of situations that could lead to this, could be things like pneumonia or bronchitis, or the obstructive pulmonary diseases. Then there is another one that we call the crackles. Now, with the crackles, it sounds like bubbling sound. You know, it's like, I'm sure you've all heard things like paper. When you crumple the paper, it makes very, very funny sounds. So when the person is breathing in, they are making that crumpling like sound. Some people have equated it to, say, like when you have a little pan with a little oil frying and you put some drops of water, you hear that crackling. Now, that kind of crackling is usually sharp, and we call that the fine crackles. But the one for crumbling the papers, producing a similar sound but more coarse, is what we call the coarse crackle. Now, there is also another one which I actually have not included it here. It's called the stridor. So I'll just put it here for the sake of so you call it the stridor. Okay, so it won't type. You know what is happening. So again, with the stridor, now stridor and rhonchi will be very similar, but with the stridor. But I'll give you, I think I have a video that shows all those different sounds so that you can listen to them and compare them to what is written here. And with the stridor is also when you have a narrowing of the upper airways, and you find that it occurs like in somebody who has a very, shall we say, a blockage of the large airways. So all these big amounts or the big volumes of air are trying to pass through very narrow spaces, so they are going to cause that rough sound. So I'll give you videos that will give you all these different sounds and you can relate to them, although I'm hoping there is nobody who will produce these sounds in the lab. Now from there, when you're looking at the chest sounds, the other sounds that you're likely to come across is the heart sound. So you can place your stethoscope around the heart region. And as you can see in this diagram, remember that your lung is located where the heart is not. So you can see within the ribs, you can draw the outline of the lungs. So it is within the ribs here, but on this area. So it is protected by the rib cage. So we have the two lungs on those sides. And you find that one of them will come and try and wrap around the heart, but you find that it encloses the heart region. So you can place your stethoscope in different parts of the heart, and what you're going to do is you'll be listening to two sounds, and we call them the lab dub, because there is one that is very very dull, and once that happens, it is followed by another one which is more louder. It's the dub sound. And immediately after that, it pauses a bit and starts again, lapped up. And we'll see when you're doing renal and cardiovascular physiology, you'll be told the reason for those two sounds. For now, we just do it because it will be part of the sounds you're going to encounter when you're listening to the chest. Of course, if you listen to somebody's chest and you hear there is only one sound, or maybe one is really prolonged before the other, you find that there is a problem with that person. It's good to highlight them so that they can go and have their hearts checked. So I will not focus so much on the heart sound because I'm sure you're going to have this repeated. So I just needed you to know the two sounds. One usually occurs as the valves close during what is it called, diastole. When the heart is expanding, the valves will close. And then when the heart is contracting, the other valves will close. So in both cases, the kind of sound you'll be getting is during the valves in the heart closing. So we are going to see all that when you're doing renal and cardiovascular physiology. So now the last one, before I go to the GIT sounds, do you have any question on the chest? Any question? Okay, so now the last part is when you're listening to the abdominal sounds, and actually this is what ties to what we have been doing in class. So we discussed motility as one of our last topics, and when we are looking at motility, we are looking at movement through the GIT. Usually, we'll find the esophagus will pass and go all the way to the diaphragm, and around this region is where you're going to find the stomach. So from the stomach, we have the duodenum, and all the intestines are coiled around the abdominal region. So this is the area that focuses on the stomach, small and large intestines. Now, under normal circumstances, there are different sounds that we expect depending on whether you are in the fed stage or you are in the fasting state. When you have just fed, when you have just eaten, you find that you're going to have a lot of activity in the upper part of the abdomen because you stimulate the stomach to start contracting. You'll also stimulate some activity in the lower through the short reflexes. You remember the gastrocolic reflexes. You're going to start causing some movements. So you do expect to have some movements which are initiated because of feeding. Now, the longer you stay without feeding, you get into what we call the fasting stage. And what will happen is that the food will have traveled through the small intestine and you'll have started the absorption process. And what will happen is that now, as you empty the contents, you're going to secrete the hormone motilin. And what motilin does, it will start initiating the migrating motor complex so that they can come and clear the GIT. And as they contract, they cause those movements. They are going to also cause sounds to occur within the abdomen. So you are going to hear all those sounds. And at times when you are very, very hungry, you start hearing the grueling sounds. Those sounds are being caused due to the presence of the motilin, initiating those migrating motor complexes, which are sort of cleaning the insides of the lumen. So when you go to the lab, some of you may have fed, others may not have fed. I don't know what your status will be. So I don't know the kind of sounds you are going to expect. Ideally, you should expect about a sound to occur maybe about within 5 minutes, you should be able to hear some sounds. So some cases people have listened and they said, oh, we really waited and we never had any sounds. But again, like I said, it will be dependent on quite a number of things, including the fed status. Now, the other thing that you can be listening, even when you're doing the abdominal examination, remember the four components of examination also apply with the abdomen. So the inspection, check if there is any lesion in the abdomen, check if there is any redness, any swelling, any opening, any injury, or any scars. So you must do the inspection first. Number two, you're going to do the percussion, and you're going to do also the palpation, and you're going to do the auscultation. So whether you're doing the chest or whether you're doing the abdomen, you will have all those four components applying. Now, the order in which they follow will differ when you're dealing with the abdomen versus when you're dealing with the chest. So when you're dealing with the chest, you can first do the auscultation, listen. That if you first do the inspection, of course, observe. Then you can do the auscultation, listen, and then you palpate or you do the percussion. When it comes to the abdomen, you cannot, the auscultation starts with the abdomen, not with the chest, because with the abdomen, if you start with things like palpation or percussion, you are likely to stimulate events happening within the abdomen. So the order that I've given you, where you do the inspection first, then you auscultate before you do percussion and palpation. So that will be for the abdomen. Inspection, then you auscultate before you do percussion, and then you do palpation. The order is in that way because if you start palpating, you're going to move stuff within the GIT. If you do the percussion, you're interfering also with what is there. So it is likely to interfere with the sounds that you're likely to get. On the other hand, when you're dealing with the chest, you can finish up with the auscultation. So you can do the inspection first, and then you do the percussion, palpation, and finish with the auscultation. So I think after you do that, you will be having results to tell us so that you can, I think that is the last thing that I had to present. So I say there's a slight difference between what I have, because I have put some other diagrams, but I think, let me see, this is what we have. So are you able to see the screen that has clinical examination of the respiratory system?
Yes, Prof.
Okay, so I think this is what Kwena has for you. And you see that this one has more precise instructions. What I had has a lot of theory. What you have here is more of the practical component. So what I will do is I will upload the one that I have just used for the pre-lab. I'll upload it on Blackboard and I'll label it pre-lab. And then for this one is the one that is giving you the precise instructions of what to do. This is what Kwena is likely to give you in the lab. So I think with that, I've done a lot of talking. Yeah, it still has the same. So I think to this we shall add the strider. So they are very similar, only one has more details on the hands-on procedure, the other one has more details on the background. So I'll avail both of them to you so that using the two, you come up with the reports. So any question before I let you go? But I will take attendance. No question? Then I think it's a bit late. I will allow you to stop recording and